Hello and welcome everybody to this session on simulating health care outside hospital. We're delighted that you've been able to join us today. We've got a number of people from all over the world actually on this webinar, which is always very exciting for us. And we really hope that this be a helpful session for you. Just a couple of housekeeping messages before we get started. First of all, I should say that my name is Claire Cordeau. I lead the healthcare team here at Simulate Corporation, and I'm going to be presenting this webinar to you today. If you're using the audio, can you please make sure that it's set to mute so that if there are any noises off, not everybody needs to hear them. And also, if you have any questions that you want to ask, please just use the chat panel on your right-hand side to ask them, and then we'll pick them up at the end. If we can't pick them up all at the end of the session, then we'll be giving you a link through to our LinkedIn page, and we can continue the discussion there. After this session, the recording will be available on simulatehealthcare.com, and we'll send you an email to let you know that it's available together with the slides. So what I want to talk about today is healthcare outside hospital. I'm going to touch on the policy agenda to start with, and then I'm going to go on to talk about how simulation can help. You can see that I've got 4 areas that we're going to talk about there. I'm actually going to concentrate on chronic disease or long-term conditions, the emergency care flow, and managing community workload. We were, as I think you've probably seen from the information that went out, going to be able to present something on obesity and weight management. Sadly, that's not available for us to talk about yet, but the person who's been developing it hopes that they will be able to present it soon. We're very much looking forward to seeing that, and we'll let you know as soon as it's ready. And then finally we'll take some questions, and we have an offer for you at the end of the webinar. So first of all, thinking about health policy. Now, I know you all know this very well, so I won't go on talk about it too much, but supporting people outside hospital has been seen as one of the ways of not just supporting patients to have better outcomes and to be kept and looked after in an environment which is more conducive to them being able to be part of their family and the community and give better outcomes, but also as a way of managing costs and increasing demand within the health service. And some of the reasons for this are mentioned below. It provides more accessible care. In some cases we've seen that it prevents exacerbation. People are better managed in the community. Therefore they don't have perhaps some of the unnecessary visits they might have to the hospital, which saves on costs. It can also speed up hospital discharge if there are better services available 24/7 in the community. That reduces length of stay, and of course most importantly it improves patient outcomes. And wherever you are working, whether it's in North America, in the USA, or whether it's in the UK, we're all looking at the same thing. And you can see there I've flagged up the Accountable Care Organisation operating model, which is looking at a whole system and all the parts of the service that people in the community might be accessing, and also some of the headlines from the NHS where there's a constant concern about the level of demand on emergency services and how we can relieve the pressure on hospitals. So when you look at some of the research, you can also see that actually as a strategy that has been working to an extent. So you can see in that figure 1, the average length of stay in acute hospitals is reducing in a number of different countries over time. And in the second table, you can also see that when you're looking at the growth in inpatient and outpatient care expenditure, it's outpatient care expenditure that is growing the most, and in most cases inpatient care expenditure is in fact reducing. So we've been putting these strategies into place. It looks as if that's the sort of thing that is starting to pay dividends now, but there's and I'll come on to some further evidence about the things that are working and how simulation might be able to help. and then just looking at some of the evidence. I found the Getting Out of Hospital paper by the Health Foundation extremely useful. It's gone through the peer-reviewed evidence for studies across the world, looking at what the evidence is for supporting people at home, increasing intermediate care, looking at early discharge. That's freely available. I do commend it to you. And there's a table which looks at what the impact of some of these policies are, and that's interesting because it's by no means obvious that there will be a benefit from any or all of these initiatives. In some cases there's no detriment, which is great. In some cases there's a benefit. In some cases, in some of the studies, there's no benefit. So it's well worth looking at that. But the big question is, whatever the evidence says, it's what you as a system, you as an organisation working with your colleagues wish to do, and understanding what that means for the system and what it means for individual organisations and departments within an overall healthcare system. And this is where simulation can help. So if you're looking at a service and system redesign, what you want to understand, particularly where there's no real definitive evidence, but you know that it must be better to be looking after people closer to home and getting them out of hospital when they don't really need the bed, you want to understand what the impact might be on your whole system as a result of making those changes. And so most people want to understand that in terms of the flow of patients through a system, the costs that might be incurred, and where those costs are incurred, who are the financial winners and losers in any one of those scenarios. So where are you losing money, which organisation will bear the brunt of it, and particularly where there's no historic data in any of these areas. You've got some peer-reviewed evidence, it's a bit inconclusive, you've never done it before, you can use all historic data to look at demand, but it's actually quite difficult to use it to look at how that might happen, what might happen in the future. So you're wanting to understand the impact on organisations, on costs, and very importantly on your patient outcomes. So simulation is a very useful technique to use where you've got a number of uncertainties, there's a significant amount of complexity, and the system isn't totally in your control. So I'm just putting up a picture there of the health and care system flow. Now you'll know this very well, but we're starting from the viewpoint of looking at a given population, so the population that you're responsible for, and then how they move through primary and community care services into the hospital and then back out into the community again, and what support they might need. And there are a whole range of different potential barriers, issues that affect how people flow through the system. So there might be a lack of access to services for a whole range of reasons. We know that vulnerable groups are perhaps less likely to use health services, or maybe only use them when they're really, really, really sick, and not necessarily picking up the more routinely available planned care services. If services aren't available 24/7, then perhaps there's more of a likelihood that people will go to whichever service is available, which might put an unnecessary load on that service. And we know also there's differences in how the rural and urban populations use services. So that all happens before the front door. Once you're in the hospital and you're being discharged, then if there's the lack of capacity or appropriate services outside the hospital, or even as a step-down type service within the hospital, then that creates a delay, and people start backing up within the hospital. So it's hard to know where it is you should be working in that system in order to improve the flow, and which one of those areas is most important, and where you might start. So simulation is a helpful methodology in allowing you to think that through. So the first case study that I want to talk about is about chronic disease or long-term conditions. This is a piece of work that we've been doing with NHS Improving Quality, NHS IQ, nationally in England, and I'm delighted that they've allowed me to talk about it today. Now, this has been a national project called the Year of Care for Long-Term Conditions, and what it's been trying to do is to look at people with long-term conditions as a cohort and understand how they use services and what happens if you were able to identify them and proactively manage them. And if you were to apply an annual capitated payment or tariff, how that would work in practice, where the money would be likely to go, would it meet with the needs of that population, would you be short of money, and how you might incentivize the different organisations providing care for those people to be part of a whole system managed care methodology. So we started off using risk stratification tools to identify and manage those patients and look at those questions. And our first point was to think about the flow as, well, we have a population, we have a set of patients who are at risk, if we identified those through our different risk stratification tools, we then clinically assess them, and there'll be a set of services that they'll use as a result of that clinical assessment, and there's a likelihood that there'll be an exacerbation at some point during the year, maybe several times, which will mean that they'll end up in the emergency department and perhaps an admission. So that's the way we started thinking about a pathway in a very simplified way. And that was the first interesting piece, really, which was we discovered that there was no real correlation between somebody's risk score and their level of need. So when we got to the clinical assessment, it didn't necessarily agree with the risk of patients. So that nice, neat, linear process that we thought we mapped out wasn't really going to work. So in order to try and understand what's actually happening, we went back to the data, and I'm very grateful again to the NHS IQ and the pilot sites who've been working in England for being able to share this data. And I think this is really interesting. What we're seeing is that about 30% of people over 75 years have multiple morbidity, and you can see how the number of LTC being long-term conditions, number of long-term conditions or chronic diseases increases with age. Now, this has been tested in Somerset. It originally was produced by the Scottish School of Primary Care. So, you know, this has been tested in many places, and we get similar results. We can also see that it's more common to have multiple conditions than it is to have one single condition. So looking at and caring for somebody with one of those conditions without looking at the others is not necessarily helpful for those patients, because they will be having multiple conditions, and so that means multiple visits. And if you're treating them in silos, it's probably not as efficient as treating them as a whole person. The next slide is looking at that group against cost. So on the left-hand side, you can see the average annual cost per patient. And on the right-hand side, you can see the number of people within the population. And then the red line there is showing you the number of people, and then you can see how many of them are likely to have long-term conditions and correlate that with cost. So you can see where the costs are starting to come. And when you look at the main contributors to health and social care costs, you can see that it's the acute, it's the emergency admissions that are causing the majority of that cost. And then one of the other interesting factors, Kent had some data which allowed them to view how patients use services and their costs over 3 years. This is the same group of patients. And what you can see here is how they were risk scored year on year. That's that red line. And when you looked at at multimorbidity, and you looked at that group by multimorbidity rather than risk score, the costs are slightly less, but you can see that same pattern. So we're interested in this idea of a crisis curve and how that works out in practice, because it clearly has an impact on costs. And you can see that there is a crisis and then people stabilize after a period of time. And you can see also that following a crisis, more community mental health and social care services are delivered to people. So again, having the crisis appears to trigger the support, and I think one of the things we're always asking ourselves, and particularly those of us who are very familiar with Kaiser Permanente triangle, is about how you can get to people before they have their crisis. And then this is from one of the London sites, and this is showing that there's some indications that if you have an integrated care service looking after individuals, so that they've got an integrated care plan across all services, then that can change the sort of services that are delivered to people. So you can see at the bottom on the right-hand side, those that are known to their integrated health and social care team tend to be getting more community mental health services and tend to be using less of the acute services. So from our own evidence, whilst the peer-reviewed journals in some cases are not conclusive, from the evidence that NHS Improving Quality is collected, you can see that there is a case for having this community service which might be helpful. So with all of this data and this kind of complex picture emerging, our job was to create a simulation that allowed people to test their own assumptions using the assumptions that had come out of the national picture. So some of these lessons that we'd learned, we wanted to be able to make available to people that weren't in that early group of pioneers, so that they could understand what the impact might be. And you can see on the screen there our picture of the long-term conditions year of care simulation. And what I'm going to do now is to go through and explain what it's doing. So what we're looking at in this simulation is the likelihood of patients accessing services, but we're looking at how they transition through state. So we're expecting that people are identified as being at risk and having a number of long-term conditions, so that they're seen as part of this group which would have the capitated payment. But as they transition through the years, there is a likelihood that they might move from a lower risk state through to a medium, high, and maybe very high risk. And so we wanted to be able to model that movement between those different states. And we were looking at patients by their level of acuity, so the risk that they might have, and also by their increasing number of long-term conditions. So patients in each state have a likelihood of accessing types of services. So we've looked at all the services that a patient will be likely to have, so whether that's in the hospital, whether it's in the community, whether it's mental health services, or whether it's social care services. And we've also looked at their likelihood of accessing those services more than once. And each time they access those services, there's a cost applied, and again, we've got a wide range of potential costs that could be associated with those services. So what we've done is we've taken data from the pilot sites from NHS IQ and put those in there as a default, and then we allow users to change them so they can be localized, so that they can test how that works locally within their own system. So underlying this, for people who are interested in the complexity of the model, and I'm not going to dwell on this,
the data builds an underlying discrete event simulation model. So you don't have to worry about knowing how to build simulation models in the final product of this. It does it automatically with the data that you put in. So the results that we can see then are looking at the number of patients in each state by year. So you can run it over a number of years and see how the number of patients might change year by year. And of course, some of them are going to die, some of them will be discharged, some of them will move into the next state, and there'll be new patients coming in. So you can test all of those different potentials. And you can also look at the average cost per patient. So that's quite a high-level view of the results that come out. And you can also look at a lower level at the cost of each area of service and organisation. So if you were wanting to say, well, we think we're going to be able to manage to have less activity in our hospitals, because we're going to be increasing the number of people that we identify in the community and proactively looking after them, then the hospital will probably want to know what that means for them financially, and so will the community. So this enables you to drill down into the sorts of services that people might be receiving as a result of those changes and how much they're all going to cost. And then finally, we're looking at cost by state per year and comparing that with the capitated payment. So again, you can see halfway down this slide here that you can set your own tariff. Now we've just put one in there to play about with. If you had in your mind as a system a set of organisations, the sort of amount that you thought you would be expecting to spend for each type of patient, you could test out through this model how that might work in practice, and whether you'd have enough money in order to meet the needs of your patients. And again, you can see where the majority of those costs fall depending on the group of patients that you're looking at. So how you would use this model is to select your population, and for the England version of the model that we have, I'm just moving over to the model here, you can see that there's a number of different populations uploaded already. And then that gives you the number in the population, so you don't have to worry about looking it up, although you can change it. You can put in the percentage of eligible patients in that population from your risk stratification, and you can set them to be in particular states at the start of the model. So obviously everyone's in a slightly different position when you start the model. And you can also put in the expected incidence for your new patients. So each year you're going to expect patients to come into your model in slightly different states as well. And then you can put in your data, so you can look at your service access. So if you're a very high need patient, what your likelihood is of going to the emergency department, having an emergency admission, having other services as well. And you can also set the number of service attendances that you would expect. So you can see here the proportions of patients who'd be likely to have a number of different emergency admissions within a year. You can also set your transitions between, at the moment we've just set this as 80% being in very high and 20% dying, but if people transfer from state to state, you can set this here and test how that might work. And you can also put in the distribution of costs. So all of the assumptions that we used in the national programme to test these out are here in the model, so anybody can use them to understand what the impact might be. We then have a couple of scenarios built in, but people can also build in their own just by changing the data, but to look at whether the population is known to an integrated care team and receiving that community support, or whether they're not known to that team, and understand how that might impact. And then as it's run through over the period of time, you get the results running through, and you can either run a trial, so multiple runs of the same model, which gives you much more robust results, or you can run it an individual time. And you can see now I've got activity building up in the different contacts that this population is creating, and it's running over 3 years. I'll just speed it up. And that will then give me 3 years worth of data, and I'll be able to have a look at those results when it's finished running in my results panel. So our aim with this working with the national sites has been to enable people to use those national assumptions to ask different questions, those different what-if questions, to understand what might happen if they manage their patients differently, and also if they decided to apply a capitated tariff. I'm just going to move through these slides I've shown you already. And people can test whether they're known to that integrated care team or not. They can test against the proposed capitated payments. They can have a look at what happens if they change the variation in cost for services. So we found from the data that actually there was a huge variety of costs for different sorts of services. And what happens if they decrease transitions through states. So if somebody has 2 chronic diseases, what happens if you could stop them from developing the 3rd, 4th and 5th? And I think the important thing for this and why it's helping is it's helping systems to plan for demand and also their improvement scenarios. But really importantly, it's helping negotiations between healthcare providers. So if you have an overall system, and I know this is true for the accountable care organisations, and you're looking at what a change might mean to different parts of that system, in the NHS what's been happening is people have been discussing with each other where the cost is going to fall as a result of doing things differently, and working out what the incentives might be to encourage providers to work together. So it might be that for one patient who has a capitated payment, in fact the hospital might have a payment for providing a service even if that patient doesn't necessarily use their services, because what you're wanting to do is to incentivize that provider to pass the patient to the most appropriate place to be looked after. Now this is all really new stuff. It's exciting, I think, because it is so new. We've tried to build the simulation to help people think it through. We expect people to use this simulation to test out how it might work, but to continue to learn more about what really happens for people who are living with chronic conditions, long-term conditions, how they use services, how we might improve that and look after people more effectively, and how we might financially incentivize that. So that's one example, one case study of how you might look at supporting care outside of hospitals. That's quite a whole system one. I'm looking at another whole system one now, but this is very much looking at the emergency care flow. And we were working on this with Martin Ware. Martin was hoping to join the webinar, but I know he was travelling between different sites, so I don't think he's managed to get here, but he's been happy for me to talk about it. What they were wanting to look at within their healthcare system was what was the impact of increasing out-of-hospital services on their cost and capacity, and particularly to look at what the current unscheduled care, emergency care flow actually looks like, and how it's expected to change in 5 years because they have an increasing elderly population. And if they increased referrals to domiciliary care direct from hospital instead of going directly to a community hospital, which is the current practice, what impact would that have both on the hospital, on the social care services providing, and on the community hospitals who are no longer providing that so much of that service? So here's the big picture that they built. Huge model. I'm not expecting you to look at that in a huge amount of detail, but it gives you an idea of where all our activity is. And what's happening is it's starting at the top end of this pathway, starting with urgent care, moving through all the different things that might happen as a result of an emergency, eventually into the hospital, and using different types of beds before being discharged either to a community hospital or to domiciliary care or home. Now, they validated this. We built this in Scenario Generator, which is our population health whole system modelling tool. And when they ran through the model with the population data for the area, they set the percentages routing activity from one part of the system to the next, so that they had a pretty good match between their own local data and what the simulation was producing. So you can see that in the table there. They put in the costs for a hospital bed on a daily basis, so they could measure the impact on reducing or increasing length of stay, and also for community beds and the emergency department. And they also put in the length of stay. And when they ran it through 4 or 5 years looking at population increase, you can see how the overall demand might increase, and also what that would actually mean for their emergency department demand and their admissions over that period. So their potential domiciliary care scenario was what would happen if they increased their direct referrals from hospital. At the moment, they had 30% of their, what they were thinking about doing was taking 30% of their referrals to community hospitals and sending them to more supported care at home provided by social services. What they thought would happen was it would be likely they'd need another 2 days in the hospital for the assessment part of that process to take place. And then they were looking at different types of care packages, whether they were complex or maintenance or rehabilitation program. And you can see that how they've costed that. So they went into what happens in domiciliary care services in quite a lot of detail. What they found was they would make a 2.6 million savings overall, which was very encouraging. But of course, social care, social services would be spending an additional 4 million, whilst healthcare saved 7.6 million in their community hospital. And for the community hospital, what that would mean is that the utilisation of beds would be reduced by 25%, and their maximum bed occupancy would be minus 90. So that's quite significant, and actually that would equate to an entire community hospital. So they had the opportunity of decommissioning, if you like, a total community hospital. But obviously social services would want to know where they were going to get that additional 4 million. But you could see that the discussion was starting to happen around a negotiation of shifting funding. So from the healthcare point of view, actually it would be possible to start to talk about shifting money over to social care because of the very significant savings that they felt that they could make. Of course, there would be that additional funding required for the additional length of stay whilst assessments were carried out. But in fact, their maximum bed occupancy only went up by 10, which is an overall additional 1% utilisation. And they felt that actually that kind of result was a result that the system could live with. And what it enabled them to do, and this is a paying organisation, a commissioner, who was developing this model was to go to each of those different providers and say, look, here's what we found out, what do you think, what's the most sensible thing to do, if we are able to via some of our finances slightly differently, would you be able to make this change? So to provide some confidence and to allow consensus to emerge between the different providers for a better result. So that's really where the project is at the moment. I'm sure if Martin was here, he'd be able to add some more as to what's happening now. But the last I heard, they were in negotiations in order to work out what might happen. But the simulation there is helping to drive the thinking between payers and providers and across the different providers. So then the final simulation I want to talk to you about is a community team capacity. Now this is a project which is being sponsored by Tissue Therapies, who are a medical device company who are concerned with wound care. Now they have a really nice intervention which has got some good evidence for reducing the time for an unhealed wound to heal, which is great. And they can make a very good economic case for how that works. But the thing they were concerned about was what the impact of that improvement is on a community team. Now when you think that community teams, 60%, as we understand it, of a community team workload is wound care. Thank you. Somebody's very kindly saying that it's taking a long time to move from slide to slide, which I think we're there now. So when we're looking at the impact of faster healing times on that workload, what does that mean for the community team? Because if you want to drive through any kind of change, as everyone knows, you've got to get the buy-in of the people involved. And if nurses in a community team are not bought into why it would be so great to have an improvement, it's going to probably create some sort of barrier to adoption. So if they're able to understand what the impact of change would be on part of their workload, and in terms of releasing more time to care for patients or more time to see other patients, then it might be a very helpful thing to be able to do. And so what this model is designed to do is to engage with the community team and understand what the pain points for each community team are, what they're concerned about, and if you drive a change like additional activity or less time in a particular visit to a particular type of patient, what does that really mean in practice? Now we were excited about this, being asked to do this model, because it seemed to us that this is the sort of question that really needs to be answered, not just for wound care, but for all sorts of other kinds of conditions as well. And we were interested, there's been a recent paper on community team workload, and which is suggesting that actually some support is probably needed to improve the way in which community teams look at their workload and understand what the impact of change might be. And of course we're all very interested in integrating care of different people working together in teams in order to support patients. So we were quite excited about the opportunity to develop this model. And the way that we look at it is we're still coming from a population point of view. So you have a population, let's say it's an aging population, we can expect more referrals to a community team as a result of that. And what we've done is we've segmented the population into those patients who only have non-healing wounds, those patients who have multimorbidity, so actually the patients we talked about first time round when we were looking at the long-term conditions model, and those patients who have a number of different conditions but actually don't have a wound care problem. So we're trying to mimic the kind of workload that the community team is likely to have. Now in our initial discussions with the community team, one of the things that they said was really important is getting that senior clinical assessment up front so that you can get a good care plan in place for the patient, and then you need to allocate on a daily basis staff to those patients who need visits to meet with the competences of the staff team meeting the needs of the patient. And those patients will stay with that team until they're discharged, and that will depend on their healing time. So for some people with multiple conditions, their wound might heal, but actually they're probably going to be with that team for the rest of their lives because they have acute COPD or some other kind of condition. So we wanted to be able to model all of the different eventualities, if you like, of that patient cohort, but allow people to test different types of interventions which might affect some patients but not other patients. So our simulation concept, and this is, we haven't put the beautiful graphics on it yet, but we thought you might want to have a look at it because this is where our invitation to you comes in. We think this is a really interesting piece of work. We're delighted to have been commissioned to do it. We're also delighted that tissue therapies are very keen to work with people and to allow us to work with anybody who's interested in co-designing this model and in testing it out. So we want to use our understanding of having worked on the National Long-Term Conditions Programme, which has taught us an awful lot about the way in which patients use services, in order to drill down into a much more workforce-focused, competency-focused model for different patients so that the results for the individual staff concerned are very clear about what might happen if you change the way in which you deliver care. And we want to make sure that this simulation model speaks to people who are delivering this care in practice and really helps understand and drive decision-making around these sorts of changes. So just really to finish this webinar, I just wanted you to invite you to join us if this is one of the questions that you're interested to co-develop and test the community model. The benefits to you are that you get to influence the design of it and make sure it fits your needs, and also that you get to use the model. So please do let me know if you're interested in being part of that. So I'm going to stop there. I know that there are a myriad of different ways of looking at simulating care outside of hospital from that quite granular level that we've just had a look at for an individual community team, to that whole system model, the emergency flow right across the entire system, to looking at cohorts of patients and how they use services. So there are lots of different perspectives on that, and we wanted to share some of the projects that we've been involved in with you in order to start a conversation. And I'm sure you've been doing a lot of thinking about this and probably have your own models that you'd like to share, and we'd be very keen to facilitate you doing that if that's of interest to you. So I'm just going to leave it open for any questions that we've got time for now, and also reiterate, please do continue the discussion on Simulate in Health. I've got a couple of questions that have come through, so I'll just pick those up now, but please, there is a bit of time, so please do send in other questions if you have them. One person was saying that they'd like to look at the pros and cons of remote patient monitoring for the management of patients with congestive heart failure and whether simulation could help with that. And I'm going to take that actually with another question, which was about whether simulations tally with what happens in practice. Because I mean, I've been involved actually with remote patient monitoring for patients, where we've been looking at the evidence from trials of what happens when you when you monitor patients, and using that to drive a simulation for the population and understand demand in order to work out whether it's worth investing in that new technology. And that was, again, helpful in driving the decision making around adoption there. So I believe that can be done, and I think it's a matter of looking at the typical pathway that patients follow through the congestive heart failure processes, and then looking at the impact of remote monitoring. But what you'd need to do is to use the evidence from any trials that are being carried out with those patients to see what the impact would be on your population. And I know some of the evidence around remote monitoring is great, and they're all slightly different devices, and different people have different sorts of results. It'd be very important to get that from the vendor of the remote monitoring device that you were particularly looking at, and so that you could test that in your model. The other question about, does this tally with what happens in practice? Some of the models we've shown today have been very much about driving thinking in a bit of a new world, and I think they're at quite an early stage. So some of the sites that have been involved in the long-term conditions pilot have changed their practice and are starting to see the impact. I mean, I think it was exciting to see that impact of the site that have been providing where patients were looked after by their integrated care team. You could really see that they were tending to use less hospital services, less emergency hospital services, as they were using more community services. So that was one site. They were pleased with that, and they were continuing to carry along that route. We do have also examples of other people's work, not our own, where they've looked at something like adopting new diagnostics for people with heart failure on the basis of clinical evidence that this is a good thing, and seeing and modelling through the likely impact on those patients and also on cost prior to adoption, deciding on the basis that it wasn't going to cost them, it was probably going to save a bit of money by the time they'd modelled the outcomes, that it was worth doing, and then finding out quarter by quarter that they were actually spot on with their predictions. So we've seen those as well, but I do think in this sort of whole system care outside of hospital question that there are a lot of variables there, and we're just getting the evidence coming in now. But what's really important is that where you've never done this before, and there are lots of different organisations involved, trying to develop that dialogue and test out the improvements that you think might work and see their impact on other organisations is a really helpful technique. Any other questions? Okay, well, I'm going to close down the webinar now. Thank you so much for joining. Sorry about the slight technical issues we've had. It does sometimes slow up a little bit, but I hope it all made sense to you. The recording will be available, as will the slides, on our website, so do go and revisit it there. Do join in the discussion on our LinkedIn group, and keep talking to us. And just to let you know that in August we'll be running a further workshop looking at improving patient care pathways. What we're going to be looking at specifically are single patient care pathways, and what happens if you put in a new intervention. So very much picking up the sort of remote patient monitoring type question. Now, because August is very often a holiday period, we're not going to run it at a specific time. We'll let you know when it's been recorded and up online, and then you can access it at any time you like. So I hope that's helpful. I hope if you're having a summer holiday, you have a great one, and that you join us at some point remotely for our August workshop, and we'll be letting you know when that's available and what we've got planned from September. Thank you very much indeed for your time.